Good afternoon. I will be talking about the impact of low-energy femto laser pretreatment on macular thickness and micromorphology. We know that pretreatment with conventional high-energy femtosecond lasers has shown to provoke inflammatory reaction. This is due to prostaglandin, inflammatory cytokine, and the depletion of other factors. There is a paper out reporting on a significantly higher level of prostaglandins in aqueous immediately after high-energy femtosecond laser treatment, increasing the normal levels to a factor of 10 to 20. There are more side effects of high-energy femtosecond laser application, acidic shift, and temperature rise in the anterior chamber. Consequences of clinical side effects are intraoperative miosis, ocular hypertension, cystoid macular edema, and endothelial cell trauma. The new concept of ZIEMER is low-energy femtosecond laser technology. And the essence is that instead of using high-energy pulses with low frequency, low-energy pulses are used with high frequency. So the pulse energy is reduced to about 1/10, while the pulse frequency is increased by a factor of 10. This results in reduced spot size and energy. How is this attained? This is attained by reducing the angle of aperture or the focus lens by relocating the laser optics into the handheld applicator in close vicinity above the eye to be treated. So we investigated the impact of such a low energy laser on intraocular tissue trauma. We need sensors to describe or measure this trauma. There are two sensors. One is the level of inflammatory mediators in the aqueous, and we use prostaglandins and the interleukins as markers. And a second sensor is the macular thickness and the macular micromorphology. We know that if you induce intraocular tissue trauma, you get a rise of prostaglandins and interleukins, and you get central retinal thickness increase, irregularities of intraretinal structures, maybe subretinal fluid accumulation, intraretinal cyst formation, and finally, it might end up in cystoid macular edema formation. So we did a number of studies to answer the following questions. One is, does femtosecond laser pretreatment reduce ultrasound consumption? And second, how does femtosecond laser pretreatment impact intraoperative tissue trauma? By investigating aqueous inflammatory media levels and changes in the macular thickness and micromorphology. So there are two PGE studies performed investigating or comparing the post-operative prostaglandin levels after low energy femtosecond laser pretreatment, cataract surgery versus pure manual surgery, and one investigating pre-fragmentation first versus capsulotomy first. We published the results of PGE study number 1 recently and compared that to the literature reports on high energy femtosecond lasers. And you can see here that the prostaglandin overall prostaglandin levels after pretreatment with a high energy level was significantly increased as reported before, while when using the low femtosecond laser, there was no increase in aqueous PGE levels. This is also also shown in a second study with high energy femtosecond lasers, that increase of PGE levels compared to no increase with our study. We also investigated the increase of cytokine release and compared that with a report from China. And again, while high energy lasers significantly increased the level of cytokines of interleukin 6 and 1 beta, the use of the low energy laser did not show any such increase. The second or third study we did was the FLAME study. And this was meant to answer the question whether the pretreatment reduces the ultrasound consumption and what are the changes in macular thickness and micromorphology. We had a similar study design years ago when we compared posterior optic buttonholing to standard capsular bag fixation of intraocular lenses. And this showed, you can see at that time, the high resolution OCT imaging showed there was no difference between the two eyes. And you can also see that the increase in retinal thickness was not statistically significantly different in both groups. Even more, the numbers were almost the same in both groups. So we applied the same study design to the study comparing the impact of low energy FLACS versus manual cataract surgery on the macula. We both surgical techniques were exactly the same, with the only difference that manual capsulorhexis was used in the one group versus femtosecond laser capsulotomy in the other, and that manual 4-sector nucleus division was used in the one group, while a 6-sector femtosecond laser nucleus division was used in the other. You can see here the two videos in both groups that compare the techniques. The patients and methods, it was designed as a prospective randomized intra-individual comparison that was statistically powered, 50 patients. Comparable mean nucleus hardnesses were selected, log3 grade 3, and only one experienced surgeon using the same standardized surgical technique did all the surgeries. Femto group ZIEMER Z8 LDV low energy, femtosecond laser pretreatment, and Phaco in both groups, ultrasound assisted forced fluidic Phaco aspiration. The outcome measures were intraoperative effective Phaco time as a measure of ultrasound consumption, and central macular thickness and micromorphology pre and 1, 3, and 6 week post-surgery as assessed by high resolution OCT imaging. Concerning the results, effective Phaco time in both groups, not different. Generally, the EPT was very low. You can see it was in the manual group 1.9 seconds and in the laser assisted group 1.8 seconds with no statistical difference. Regarding macular thickness, means and SDs, you see here that both groups were essentially the same. There was no statistical difference. You can see here the thickness was 275 microns in the means pre-op and 1 week post-op, and 280 at 3 weeks and at 6 weeks. This is shown as box plots and as histograms, and shows that both groups were have the same thicknesses of macula in these time frames. Also, differences between groups were not statistically significant different. So the conclusions are, FLAME is the first study that intra-individually compares work of nuclei of comparable hardness with and without femtosecond laser pretreatment. With the specific ultrasound assisted forced fluidic Phaco aspiration technique and instrumentation used, no difference in effective Phaco time as a measure of ultrasound consumption was found. Workup of the pre-sectioned nucleus, though, was experienced optimally controlled, easy, and safe. As previously shown for aqueous PGE and interleukin 6 levels, no difference in post-operative macular thickness was found with the additional use of a low-energy laser. So Z8 low energy femtosecond laser pretreatment does not induce intraocular tissue stress. And second, though not found in the present study, femtosecond laser pre-sectioning of the nucleus may help save US energy and make nucleus workup easier and safer when less efficient techniques and instruments are used. Thank you very much for your attention.
Thank you, Rupert, for that interesting talk. Can I ask just one question? So one was pertaining to the study. Did the patients use the any non-steroidal inflammatory drug after the operation, or was it only as a pre-treatment in the femtosecond laser group? And the second thing is that whether you could just make a comment about energy settings as well that you will use for the femtosecond laser with respect to the density of the cataract, so the fragmentation and the capsulotomy energy.
Yeah, the capsulotomy energy was set at 90%, and the for nucleus 3 grades was set at 120%. And in PGE study 1, we only used 1 drop of NSAID preoperatively half an hour before surgery. And in the second group, comparing capsulotomy first versus fragmentation first, we did not use any NSAID pretreatment at all.
Great, thank you very much.